Guess I'm the last one. Wish I had a joke for you, but I don't, so. Okay, so my topic, I'm Kevin White, by the way. I'm from the Orthopedic Institute of New Jersey, and my topic is the arthritic conditions of the foot and ankle. The goals of this talk really is not only to understand some anatomy and biomechanics, which has been well described by previous colleagues, but also to understand when the patient comes to your office with these conditions, ankle, midfoot, and first MTP joint arthritis, is to understand by knowing some of the anatomy and biomechanics a systematic way of how to approach them, and to align how you initialize a treatment with what I'm going to do. So we've pretty much went over this in extensive detail, but it's important to note, without going into detail with my talk, how unique the ankle joint is. It's very unique. There's a high degree of congruency, meaning that both anatomically, the way the bones are shaped, and ligamentous, what stabilizes the ankle 360 degrees around. It really matters that you understand that, because as you can see, and not going details in these ligaments here, both the lateral complex ligaments, medial complex ligaments, which again has been gone over the last few talks, and as well as syndesmosis, they all provide an inherent stability for the ankle. So when you think about how thick the ankle cartilage is, and Dr. Epstein talked about this as well, it's less than 2 millimeters thick compared to about 6 millimeters in the hip or the knee. Now, you combine that with the small surface area of contact stress, which is about 350 square millimeters compared to about 1,100 and 1,120 with the hip and knee respectively, at 500 newtons of stress, which is equivalent to about 112 pounds, you start thinking, okay, can you really get primary ankle arthritis? And the answer is it's rare. So the stability that you have, that we're all born with the ankle, unless you have some sort of connective tissue disease where you have natural hypermobility, it's rare to get it without any kind of trauma or some secondary cause. Some of these secondary causes are, and you see it all the time in your offices, inflammatory arthropathies like rheumatoid arthritis or psoriasis, gout, infection, avascular necrosis, tumors, and congenital deformities, such as, a very high arched, someone who walks in the outside of their foot, or a very flat foot, and they're pronating, which their arches collapse, and you have really uneven stresses, through the ankle joint. But by far, the most common reason why you get osteoarthritis of the ankle is post-traumatic, and it kind of goes back to the congruency of the ankle joint, and Dr. Epstein mentioned it only takes a little bit of displacement, meaning it doesn't have to move much, for the contact stresses, meaning the alignment of the tibia and the talus, to change really your weight-bearing pattern, where you're putting more stress in one side of the ankle versus the other. It needs to be perfect. So you look down this list, the so-called plafond fractures, the talus fractures, ankle fractures that we just went over, as well as ankle instability and osteochondral lesions, which have all been discussed. You look at these are all post-traumatic conditions that will lead to arthritis in the future. Now, again, referencing an article that shows 1 millimeter of talus shift causes reduced contact stresses at 42%. We've seen that data before. And also the medial instability, the deltoid ligament, deep deltoid to be specific. If you have an injury of that deltoid ligament, you decrease contact stresses about 15 to 20 degrees. So now, these folks come into the office, they have pain, and so I first start with a medical history, just like any one of you when you see these patients. I ask, do you have diabetes? Is there neuropathy? Inflammatory disease? Again, we talk about the secondary causes of ankle arthritis. Comorbidities, obesity, any history of trauma. Where's the pain? What are the patterns of the pain? Is there anything that exacerbates it? What hurts the most? Does it hurt most when you're walking on gravel, going up and down the stairs, getting out of your car? These all matter when you're thinking about treating them. And then when I examine these folks, I take both shoes and socks off. Why? Because I want to compare the good side and the bad side. What are the patterns of swelling, the patterns of pain? Surgical incision. Sometimes patients forget they had surgeries like 20 years ago. Then you see an incision. Then I test for instability. Again, well documented with the previous talks. Anterior drawer, tailor tilt, to name a few. And look for limitations of motion, because when you're talking about arthritis, you're talking about limitation of the motion of the ankle joint, tibio-talar joint, but also the last two down here is very important when you're thinking about, at least on my end, when it comes to the point where someone needs surgery, you need to know what are the surrounding joints doing. Now, the subtalar joint is the side-to-side joint, and the Chopard joint is the joint in front of the ankle at the level of the foot. So, again, I want to stress the importance of the effort here. When you're examining, it's those of you who have x-rays in your offices and you order ankle x-rays, it is 3 views, and it was just discussed. But it's important to get the right views because you will miss a wealth of information if you don't get it. Again, we're dealing with ankle arthritis. We're dealing with decreased joint space. We're dealing with deformities. So if there's no stress, and if the patient is able to do it and cannot, you will have a false sense of evaluation of what the ankle's really doing. So all my patients, when they get x-rays for arthritis, are weight-bearing, if they can, obviously. Now, what do they look like when they're weight-bearing? So you have this example of a patient with ankle arthritis. You see the top views, the swelling of the left ankle as compared to the right side. Again, the importance of looking at the contralateral side. Because sometimes you see the swollen ankle and you look at the other side, exactly the same. So then you're like, okay, well, maybe this guy doesn't have ankle arthritis, right? But then you look at the x-rays, then there's no doubt about that. Everyone in this room can see that it's bone on bone, and that's the hallmark of what we're talking about for this part of this talk. Now, when you see these patients in the office, obviously you're not going to tell them you need surgery, you need a replacement or arthrodesis. You have to start conservatively, and the same holds true with all of us. We start conservatively first. Activity modifications, find out what they do, right? Are they trying to run with end-stage arthritis? Are they trying to do CrossFit, which seems to be the most common thing that I've been seeing lately? You try to tell them to really cater their activities to riding a bike or just walking. Then you look at their job, right? Are they still trying to climb ladders? Are they still putting 12 hours on their feet and coming home with severe swelling? You tell them, well, maybe you should do more of a sedentary job if you can. Then we talk about weight loss. Weight loss is also important, not necessarily to prevent arthritis, but it helps with the symptoms. So I tell my patients, a pound of weight loss can equal to 5 pounds of stress less through the ankle joint. We talked about anti-inflammatories. You could use whatever anti-inflammatory of choice, whatever works for the patients. And corticosteroid injections as well, just like the knee, just like the shoulder, as well as shoe wear modification, and I didn't put it on here, bracing as well. The whole point of a shoe modification is to pick a shoe that has a lot of support. This is just one particular kind. There's a lot. It's a big industry, and there's a lot you could choose from. But the bottom line is you want to make sure that there's solid support, it's wide enough, and it has a lot of cushioning inside. And there's definitely a lot, especially the running and walking variety. Now, if it does get to surgery, which again it is rare, I have to admit. I mean, this is not, these two options up here, it's not like we're doing it every week. But when we do it, these are the options. On the right side is ankle arthrodesis, which is fusing the ankle, making two bones one. Now, the rationale behind that is to eliminate the motion, so you're not getting the bone-on-bone pain, the grind that you would get if it's still moving. The picture on the left there, or on the right side of the screen, is ankle arthroplasty, which is a replacement. Now, I was sitting in the knee talk earlier, and it is very much like a resurfacing procedure that you've heard earlier. And to take it a step further, and this is an example of a patient of mine that has post-traumatic arthritis from having ankle surgery years ago. What we normally do is we take about 1.2 centimeters to 1.5 of the articular surface, and we literally just replace the surface of the joint with metal and plastic. Now, the other option is the fusion. Again, bone on bone. And what we do, the whole premise of the ankle arthrodesis is to eliminate the motion, so there's no grinding, there's no pain when you weight bear, and the patient can go on to walk with, or even with the ankle arthrodesis, which I'll get to in a second, able to push a little bit versus the ankle replacements, which leads me to the difference. Now, why choose one over the other? First of all, if we talk about the ankle arthrodesis side of the column here, these are folks where really there's no age preference. You could get it at any age. They're more active, young. These are your construction workers that fell 20 years ago and they just have arthritis and want to keep working. This kind of surgery is used for deformity correction, and even people with a history of infection. It doesn't scare us to fuse that. Because it's still considered a gold standard to this day. However, there are issues with this. Number one, it does take a long time. There can be issues, actually pretty common with delayed healing. We tell them no weight bearing for at least 2 months. Sometimes that can go to 3 or 4 months, etc. And also there's this issue of increased adjacent joint arthritis. I talked about the side-to-side joint and the Chopard joint a few slides ago. Now, usually, if you have a nicely fused ankle and you use it, you're back to working, you're back to doing what you need to do. Later on, those joints have an increased stress, and you could bet that it's going to become arthritic and an issue later on in life. Now, on the right side of the column here, ankle replacements, these are more really for sedentary folks. This is not done a lot, at least in my hands. Usually, they're folks greater than 60, sedentary lifestyle, non-obese. They need to have a stable ankle with really no deformity and good bone stock. The reason being is, and it plays into the first issue here, there's poor implant longevity. What does that mean? Well, the total knee guys that you just heard previously can tell you their knees can last up to 20 years. We can't say the same for the total ankles. Right now, at best, we have an 8-year success rate, 90% success rate at 8 years. Most of the data are intermediate, 5 to 10 years. We have really no great 15, 20-year results. That's why we limit the surgery to those who are, really, they just want to go to the Mount Airy Lodge or something like that, Sands Casino. They just want to walk, right? They want to just go on with their life and just have fun doing what they want to do, sedentary. Now, the next topic is the midfoot. Now, the midfoot is exactly where it is. It's the midfoot, right? It's the bridge of the foot. Now, it's unique as well because really it only consists of 5 bones, but they're so important. It's what transfers the weight from the heel to the toes. And if you think about it, when you walk from heel to your toes, there's a big force that just goes straight through every time. So for the midfoot to be stable, it needs to do 2 things. Number one, it needs to be rigid. You can't have a loose midfoot, otherwise you're going to have issues with arthritis. So the average range of motion, dorsiflexion, which is going up, is about 4 to 8 degrees. Plantar flexion, about 10 to 15. And you also need multiple ligaments supporting this, which is what you need for the stability of the midfoot to accept that load from one side to the other. Now, again, evaluation, same thing like the ankle. Diabetes, neuropathy, inflammatory disease, secondary comorbidities, obesity. Where is the pain? What exacerbates the pain? You have pain going up and down the stairs, pain getting out of your car. So all of this stuff is systematically asked every time someone comes into the office. And most of the time you'll find that it is, again, post-traumatic, but in this case, also idiopathic. So unlike the ankle, the midfoot does degenerate over time, more so than the ankle, even without trauma. And you also think about deformity as well. People with flat feet and high arches tend to have a lot of pressure in the mid part of the foot, which is why I put it up here in the slides. That's one of the causes of midfoot arthritis. Here's what they look like. Weight-bearing examination, you see how it's swollen at the bridge of the foot. Then you get the x-rays, and you see right in the middle here, bone on bone in this area of the foot. Another example is someone who has flat feet. Okay, and you could see it. Anyone in this room can see that. This is flatter than the other side. Again, another reason why you have to see these folks with their shoes and socks off. And you look at the x-rays and you see, again, degenerative changes, bone on bone in the middle part of the foot, except this a little bit worse because there is a deformity, what we call a valgus deformity. It's rotated out. Now, non-operative treatment, what you could start in your office, you talk to them again about non-impact activities, sedentary jobs, weight loss, anti-inflammatories of choice, cortisone injections, and shoe modification. Now, a little different with the shoe modification for midfoot arthritis. Because you transfer the weight from the heel to the toes, right? When you walk, there's that 4 to 8 degrees of motion going up, which causes pain. So if you notice, now we're going to go into the details of the sneaker to the left here, or to the right of your screen. There is a rocker-type configuration of that shoe, and it has very thick soles. So you're asking that shoe to take the place of the midfoot as far as bearing the weight. The shoe's not going to bend, so it actually helps accept the force forward. It actually helps a lot of people with midfoot arthritis, and you could recommend that type of shoe. But obviously, if that doesn't work, then that's the time to send to us, and the surgery of choice is a fusion, at least in my hands. Now, just beware, however, and I'm sure it's happened to surgeons here, beware of the so-called midfoot sprain. And it's important because it happens more frequently than you think. Now, we have patients come in sometimes and tell you, well, I just sprained my foot, and it hurts, right? But if it truly is a sprain, you shouldn't have any radiographic issues. There shouldn't be any problems with x-ray. You shouldn't have really significant pain. The pain shouldn't be out of proportion to what you're doing, right? When you touch the foot, they shouldn't scream. And they should be able to place some weight on it. Now, if you have someone in your office that says, I have a midfoot sprain, then you look at their foot and you see this. And this was touched on earlier with prior talks. That's called plantar ecchymosis. That suggests a little bit higher level of injury, okay, which is, it corresponds with moderate to severe swelling and pain out of proportion. You get the history of folks saying, oh, I almost passed out when I hurt my foot, right? I mean, that's really more than just a midfoot sprain. Then you get the weight-bearing x-rays, and you compare to the other side, and you see a subtle difference between the space between the first two metatarsals. Then you start saying, okay, well, that's not normal, because it's not. It's a Lisfranc injury, and it's most commonly missed as far as the injuries in the midfoot. Why do I say that? Because if it is missed, it could be disastrous. Usually, delayed diagnosis equals very poor outcomes. Instead of trying to fix it, by the time it gets to you, or to me, or to them, it's fusion. And it's a very different outcome, very different surgery. And right there in the bottom of the right side, very high litigation cases, especially in the work comp world. So I thought it was good to note that as a pearl. Lastly, the first metatarsophalangeal joint, pretty much, between the metatarsal and the first toe. This is an essential joint. Well, what does that mean? Well, it bears the highest load, okay? You need it for proper gait mechanics. You need it for push-off, for balance. And you need at least 60 to 65 degrees of extension to have that ability to balance and to push off. Now, I included that term hallux rigidus up there because I do consider that, it's the earliest phase of arthritis. That's a bone spur at the top of the foot. But most of the time when you see that, the joint is arthritic anyway. So this is actually the most common arthritic issue in the foot. About 2.5% of people over 50 years have it. Etiology really is not well understood. We do know there are patterns. Trauma is associated with unilateral presentation, like if you broke your toe, dislocated it, and so forth. Genetics do play a big factor. We know that because 2/3 do have a family history. And 90%, 95% of those present bilaterally. So there is a pattern here. Again, systematically, there's like a broken record here. We talk about the diabetes, the neuropathy. Is there any inflammatory disease, secondary comorbidities, any history of trauma, worse the pain, and so forth. But there's a reason why I do that, and we're going to get on that in a little bit. But how do these patients present? they come in with pain, obviously, at the first metatarsophalangeal joint, the big toe, if you will. Their pain is always on extremes of motion. So if you take your hand and you move the toe up and down, it hurts when you extend it up and flex it down. And when they walk, it hurts right before their toe leaves the ground. And it's worse with heels, by the way. Sorry, right? Often they compensate. So they come in and they walk on the outside of their feet. Why? Because they have problems loading this joint. So here's an example. There's swelling in that joint compared to the other side, again, which is why they don't have their socks on. And then you get an x-ray, and it looks like this, bone on bone, just compared to the joint next to it, right? You should have a space there, but there's none, right there. Now, conservative treatment, again, that you could start, again, anti-inflammatories. You could give a cortisone injection. Orthotics. Now, orthotics, not well accepted. However, it is an option. Why? Because if you see there, that is a metallic or a hardened extension under the big toe, which prevents you from moving it. It's not comfortable. I've tried it on myself. Not that I have it, but I've tried it, and it hurts. But it is an option. Now, the rocker bottom type shoe, a little different than the last one, but same premise. Very, very thick sole, so it doesn't bend, and it has a little bit of a rocker to it, so you're able to roll your foot forward without bending the toe. And of course, activity modification, which is what we talked about in every single evaluation. Now, why highlight diabetes neuropathy? You must be wondering, why is that in red? Am I picking on people with diabetes and so forth? Well, the reason why I say that is because in about 7.5%, you could get something called Charcot foot or ankle deformity, which is a progressive neuropathic destruction of the joint without any trauma. They always come in looking like cellulitis first, swollen, and they'll tell you, well, I don't remember doing anything to it. And there are a lot of reasons why this can have, a lot of theories, which we won't go into now. However, it's important to note because if you miss it, because these are best treated early, you have a high incidence of wound infections, and it usually goes on to amputations. So it's important. What do they look like? Well, this is more of a late presentation. This is what's called a rocker bottom foot. You see here, you see it's swollen. You may think it's just swollen or inflamed or maybe a cellulitis, but then you get an x-ray, you see joint dislocations and bony erosions. So the last pearl is, you have someone with diabetes, with neuropathy, with a foot injury, always have that in the back of your mind, because you just never know. And that's it. Any questions?